Defects. TREV is total revenue. Defects is public health expenditure. And on this chart, you've got our national GDP growth from 2000 to 2005. You got the consumer price index. You got consolidated provincial total revenues. That's TREV. Okay, and growing at 3.5%. This is consolidated provincial public health expenditures, growing at 8.1%. That's FEX, so TREV and FEX. Now here we see FEX and TREV by province. And you can see universally across the piece, with almost the exception of Alberta. Does anybody know what they do in Alberta? They pump oil out of the ground. Huh? They pump oil, yeah, they pump oil out of the ground. And they haven't been able to keep ahead. Even with pumping all that oil out of the ground, FEX is growing faster than TREV. Now, you know, TREV is sort of like a solution provider. FEX is like a problem. Because if your expenditures are growing faster than your revenues, you're eventually going to come a cropper. And here, if we compare it over time, we compare FEX and TREV by province from 1997 to 2005. You can see what's going on. It's not looking good. Now, in the case of the province, actually done some projections to see when it is, because if your total expenditure on health care is growing faster than total revenues, if you imagine this is a road race, total revenues are running along and they're running at 3 miles an hour, and public health expenditures are running at 5 miles an hour, what's eventually going to happen? Healthcare is going to absorb all of the revenue in the budget. It's just going to happen. And so what we have done is we have made a projection of what's going to happen in the province of Ontario, one of our wealthiest, in fact, the wealthiest province in many ways. It doesn't have the oil in the ground, but it's got everything else going for it. And here is what's happening. This is what happens. This is FEX, and here's TREV. And now this is not just the amount set aside for health care. This is not the amount. This is total revenue in the province. And ladies and gentlemen, this line, this FEX line, when we projected that, we did not project the aging of the population. I'll just show you that it does not include the impact of aging population. It includes drug delisting, reform efforts, and rationalization. In other words, all of the things that we are doing to try to stop the growth of expenditure have been included. Total revenue has been overstated because we do not take into account debt servicing costs. The actual amount of revenue available is lower than we've been showing here, but because we're projecting total revenue. And total revenue includes federal transfers and includes tax increases which are already planned. So in other words, this is a very cautious projection, and what it shows is that Ontario in 2026, which is not that far away, total public health expenditures will absorb all of the revenues that are available. Now, is this going to actually happen? How many people here think that that's going to actually happen? No, of course it's not going to actually happen. But what is going to have to happen between now and then? Well, either tax increases or other expenditures eliminated, or some competition in the system, or you would reduce your health care available. Now, remember what I showed you at the beginning about what was happening to waiting times? If you were put in the position of managing the health care system of any of those provinces, and you're looking at that chart, wouldn't you be reducing access to health care? Not because you're a miserable SOB, but because you just are faced with the only one thing you can do. You've got a policy that says you got to give universal access to everybody, doesn't matter what, on the one hand, and by the way, you got to do it with that fixed amount of money. Well, how long do you think it's going to be before you find, well, I can't give it to everybody, so who am I going to give it to? Well, my relatives, of course. and the friends of the, you know, and all of these things, ladies and gentlemen, have been happening and have been documented. That if you know the head of cardiology at the hospital and you play golf with him, you get your surgery done. And if you are a physician, you get your stent put in as soon as you hit the hospital, when you need it, when you have a heart attack. And if you're a nurse and you're inside the system, you know who the good ones are and who the bad ones are. You don't send your loved ones to people who are likely to off them. And so you get inside information and you use it. All of the things that happen when you have a centrally planned system. And why are we surprised? We watched the slow motion decay of the Soviet Union over 70 years. We watched them go zzz. And that's the principle that is contained in the Canadian healthcare system and is now going to be contained in your healthcare system if you do it. I guess I'm running out of time. I promise. Well, and by the way, we're not the only ones who are saying this. These are all the commissions that none of them mentioned, by the way, in the Blue Ribbon Commission's report, staggeringly. I mean, we have had this has been the main thing that has preoccupied the Canadian population for the last half decade, is the decay of our healthcare system, and not a mention, not a peep, not one jit, not one tottle of mention in the report. I couldn't believe it. And of course, these are the private sector people who've mentioned the Fraser Institute since 1990 and CD Howe. I mean, this is all right across the spectrum. We got people concerned about it. Now, I don't have time now to go into this in any detail, but the problem is overutilization and moral hazard. The cause of that is first dollar coverage, universal public subsidy, and what we need is user fees. We need eligibility for public subsidy. You cannot afford, ladies and gentlemen, in Bahamas or Canada or anywhere else to say, everybody is going to get exactly the same quality of health care and it's going to be universally applied and without any limitation. If I said that about automobiles, you would say, of course you can't, right? You would say you can't give automobiles to everybody without limitation. You can't give houses. Why doesn't everybody in Bahamas have unlimited access to food and booze, for that matter? Why not? Because you can't do it. And you can't do it with health care either. And so you got to make choices. The pretense that's built into the Blue Ribbon Commission's report is that you pretend that you can give this universally, comprehensively to everybody. It's a mythology that you should look at very carefully, and look at the Canadian example. Inadequate insurance protection. Of course we got inadequate insurance protection in Canada, and we're not delivering care. Because why? Because we're insuring oil changes. If you went to your insurance company and said, you know, I got this automobile insurance and it only covers me when I have an accident. Why don't you cover my oil changes? And my tires when they wear out? Why not? Well, it's pretty obvious, right? It's stupid to buy insurance for something you know you're going to have to do all the time. Well, why are we pretending that you need to insure people for going to see their family doctor on a semi-annual basis or whatever it takes when they get bad flu or whatever? Why should we do that? We know that that's a recurring cost of just doing business. And we shouldn't include an insurance plan. Insurance plans should cover you from catastrophe, like your house insurance does, like your automobile insurance does. And the attempt to provide first dollar coverage for oil changes is going to kill our system just as it would kill yours if you adopt it. The inefficient allocation of resources. Well, if you get central planning involved, surely we don't need any more evidence that central planning doesn't work. You know, they tried it. They did the best they could in Russia. They were hanging the guy who ran the grocery store in Moscow to make it work better. He didn't make it work right. He had black market activity going on in the back, so they hung him. Now, you can't have a better incentive than that to get people if you're going to try and force people to do things. It doesn't work. You can't force people to do stuff. You got to get people to cooperate and do what's in their interest because they're led by incentives to do so. And that's why you have to get rid of this central planning idea. The absence of payer accountability. Well, if you have public monopoly in health insurance and you don't have any user fees and you don't have any involvement by the consumer,